Good morning. My name is Professor Breymann from Zurich. I would like to give you a talk on the use of intravenous iron in obstetrics and gynecology. And thank you for listening to my talk. We know that worldwide there's around 30% of women can be iron deficient or anemic. Here you see an overview in the world of various countries and stages of iron deficiency, and the dark spots show show places of severe iron deficiency, while the less dark spots have a lower incidence. But what you see is that in the average, you can say that around 30% of women in the reproductive age are anemic and or iron deficient. Causes of iron deficiency are various. We know that there are many, especially women, have a decreased iron intake. There is a higher number of vegetarians or people with unbalanced diet. There are conditions of decreased iron absorption, such as celiac disease, malabsorption, or inflammatory diseases. Many women are prone to blood loss or heavy menstrual bleeding or blood loss on delivery. And of course, there is, especially in pregnancy and lactation, there is an increased iron demand. As we see here, the changing iron requirements pre and postpartum, you see here that especially in the first, second, and third trimester in the middle, you see the high increase in iron demand for the fetus and placenta, but also for the red cells. Almost 10-fold iron requirements are asked until the third trimester. So that means 7.5 milligram per day compared to the first trimester, where it's only around 0.8 to 1 milligram a day. So there is a high increase in iron demand. And if the iron stores are empty before pregnancy, the woman can never meet the needs of iron. Now, if there is iron deficiency and anemia, there are various consequences for the fetus, like with low hemoglobin levels are linked to spontaneous abortion, low birth weight or preterm delivery. Very low hemoglobin is linked to chronic placental insufficiency. And we also know that a low hematocrit is associated with growth retardation and medical abnormalities. In the mother, preconception iron deficiency can lead to chronic placental insufficiency, impaired physical performance, increased cardiac failure, and maternal death from heart failure and severe anemia. And also the endocrine system, such as the thyroid status or wound healing, are linked to iron status. Now, for example, this study shows you the odds ratio for pregnancy outcomes in anemia. And you see on the left the odds ratios for preeclampsia, eclampsia, preterm delivery, low birth weight, and stillbirth in mild or moderate anemia, which would correspond to a hemoglobin around 10, and severe anemia, the odds ratios, which would correspond for hemoglobin below 9. And you see that the odds ratios for severe changes in the mother, like preeclampsia or preterm delivery or low birth weight, are increasing up to 3.6 to 8-fold. So that shows you that severe anemia has a strong impact, and the greater the severity of anemia during pregnancy, the greater is the risk of preeclampsia, preterm delivery, low birth weight, and stillbirth. So preventive measures should be undertaken to decrease the prevalence of anemia in pregnancy. We also know that hemoglobin has an impact on the outcome of preterm neonates, for example. which is also an interesting observation. In this study, you have three groups of hemoglobin. The one group with the Q1 with a hemoglobin below 10.7, next group between 10.8 and 12.4, and another group which has a hemoglobin over 12.5. And what you see in the red curve is that, for example, for a gestational age of 28 to 30 weeks, the poor outcome for preterm babies is the odds ratio is around 3. So that means that for a hemoglobin below 10.7, a preterm baby has a threefold risk for a poor outcome after birth. And we are talking about the hemoglobin of the mother and not of the baby. So in other terms, if you normalize the hemoglobin of the mother, you have a better outcome of the preterm baby. There are also long-term consequences of prepartum iron deficiency in the child. So a high proportion of infants born to anemic mothers display iron deficiency themselves. You see here on the left the percentage of iron deficient infants of replete mothers, and on the right of iron deficient mothers. And you see that the odds ratio to be iron deficient is 6-fold higher. So that means that you should fill up the iron stores to prevent iron deficiency in the infant. Another problem is the iron loss and obstetrical blood loss. We know that both pregnancy and the postpartum period are prone for bleedings. That can be chronic bleedings, pre-existing anemia or acute bleedings. And we have also atonic bleedings in birth, tissue laceration, women with coagulation disorders, or vessel lacerations. These cases are all prone to more or less blood loss. And in priority, we don't really know how much will be the blood loss. Here we see in normal birth, it can be 300 milliliters to 500, but in increased bleeding or strong bleeding or at DIC, the blood loss can be quickly up to 1 or 2 or 3 liters. And if the mother has a pre-existing anemia, a blood loss of 2 or 3 liters can be poorly compensated. And therefore, we know that blood transfusion during pregnancy and birth has always a high implication. As you see here in red, there is a constant higher number of administration of red cells compared to platelets or packed cells. So we know that in all clinics, the number of blood transfusion is high in critical deliveries. Here again, if you see the blood transfusion in cesarean delivery, for women with mild anemia, that is the upper red bar, the odds ratio to receive blood transfusion is 3.4. But if you see the lowest bar in severe anemia, the odds ratio for blood transfusion goes up to 17. So a woman with a hematocrit below 25, which corresponds to a hemoglobin of around 8 to 9, has a 17-fold risk to receive blood transfusion. So you should remember that. And if we have patients such as Jehovah's Witness who refuse blood transfusion, especially in these patients who are refusing blood transfusion or have severe anemia, everything should be done to normalize anemia, because if these patients who refuse blood transfusion have severe anemia, they might die. So also in these patients, it's mandatory to normalize anemia. And don't forget that there are always transfusion complications. I don't want to go inside, but we know that many complications can set up after transfusion. And this is why today, actually, in patient blood management, we try to get rid of blood transfusion as if it's possible. The three pillars of patient blood management in gynecology are to optimize the red cell mass, to minimize the blood loss, and to optimize the physiologic tolerance of anemia. So in any surgical field, you should remember these three principles, namely the patient blood management in surgery, and this will help to prevent from blood transfusion and to use more intravenous iron and other substances. A few words to diagnostic issues. You should remember the cutoffs of anemia. You see in the upper red bar, that is the median of the course of hemoglobin in pregnancy, and then you see the lower red bar where is written anemia. This is 10.5. So remember that any value below 10.5, not 11 but 10.5, should be regarded as anemia, while levels below 11 in the first and third trimester are anemic. Here again, you see cutoff levels in various parameters. Here you see here in pregnancy, 10.5 in the second and 11 in the first and third trimesters are the lower cutoffs. And then the main parameter that we are testing for iron deficiency is the serum ferritin, which should be over 15 or 30. So serum ferritin and hemoglobin are defining anemia in pregnancy. Ferritin is the best single parameter to detect iron deficiency. You see here the ROC curve for sensitivity and specificity to detect iron deficiency. And you see the ferritin is better than all the other parameters like red cell volume, transferrin saturation, and so on. So if you use ferritin as a single parameter, it's actually enough. Just remember that ferritin is also an inflammatory marker. You see here in green the ferritin after cesarean delivery. So you see at day 0 the ferritin, and then the increase on day 1 and 2 weeks after cesarean. And you see that the ferritin in this patient is actually increasing dramatically, as is the C-reactive protein below. So the ferritin reacts as an inflammatory protein, and that means that in this period you must not measure ferritin for iron stores, because it is not reliable. So this leads us to the therapy. After diagnosing the iron deficiency, we have various formula for iron preparations. We have the oral iron preparations that can be iron salts or iron complexes. Here in Switzerland, we are mainly using these iron salts and iron complexes. Oral iron is especially recommended as a supplement or prophylaxis. I would like to point out that the WHO has no clear program to use intravenous iron in pregnancy and postpartum. So the main recommendation is on oral iron. But personally, I would like to remind you that oral iron works well for prophylaxis, but not for therapy of severe anemia. The dosages, the recommended dosages are around 60 milligram per day. We don't really know what the 60 milligram are based on. The studies with oral iron show different preparations between 30 to 80 milligram tablets. The recommendation is 60 milligram. We also don't know if every other day, for example, let's say every second day, to give oral iron might be better to give it every day for the resorption. So many points are open, and the main issue is that the oral iron has a very limited resorption in the intestine and duodenum. So one major pitfall in oral iron is that in many cases it's poorly resorbed. You also see the side effects. That means here, if you see for constipation, diarrhea, heartburn, nausea, the more iron you give, the less will be, or the more side effects you will have. and the less will be taken. 1 over 5 women will stop oral iron tablets. This is a study on 450 women using different iron preparations on the left. And what you see on the far right, where the red star is that around 18%, so nearly 20% of total are stopping the iron tablets. So around every 5th patient will stop due to side effects. There is one preparation here, which is here we have a comparison between iron-3 polymaltose and compared to ferrous sulfate. Here you see in orange the polymaltose and in gray the ferrous sulfate. And what you see concerning nausea, vomiting and constipation and epigastric problems, abdominal pain, the carboxymaltose complex is better compared to iron sulfate. So one option would be to, in a patient who is not tolerant to iron sulfate, you could switch to carboxymaltose and see if the patient has less side effects. Another problem is that if you know about hepcidin, which is the iron regulating hormone, it is released in the liver. And what we know is that high cytokines like IL-6 or inflammation are increasing hepcidin in the blood, and this is inhibiting the resorption of iron. So in cases of increased hepcidin synthesis or after operation or births, the resorption of iron is low. Again, I want to remind you that the C-reactive protein after cesarean is increasing. This itself is increasing the hepcidin in the blood and decreasing resorption of iron. Now, so we see that oral iron, it is relatively low cost and suitable for almost all women, but we have compliance issues and oxidative stress, and many women will stop the oral iron. Blood transfusion, it can be life-saving in rare conditions, but involves a variety of risks and complications. It has high costs, can be short in supply, and administrative errors. So this leads us to the smiley, the intravenous iron, and I want to give you some more information on intravenous iron now. There are various intravenous iron preparations. These are iron-3 carbohydrate complexes, such as the ferricarboxymaltose, iron isomaltoside, iron dextran, ferrum oxytol, and iron sucrose. The advantage of intravenous iron is that there is a sharp increase in after administration, as you see here in black, 50 minutes after administration of intravenous iron in the bone marrow. It is incorporated in the bone marrow. It can be used for red cell production. As you see, there is also activity in the liver, spleen, and bone marrow. But actually, while the in blood, I mean, but actually while the iron content in the bone marrow is increasing over time, it is decreasing in the other compartments. So the iron can be used for erythropoiesis right away in the bone marrow over a long time. We have started in 1995 with the first studies using iron sucrose. So this is a backup experience of around it's more than 20 years. And that we have experience with these substances. And the trials with iron sucrose, this is a study from 2005, where you see on the left side the treatment with hemoglobin of anemia in pregnancy. You see in black the increase after iron sucrose, and in the transparent bars after oral iron, it's easy to see that the hemoglobin with iron sucrose is higher with the intravenous use until the postpartum period. On the right side, in the box plots, you see the increase in ferritin, and of course also ferritin iron stores are higher using iron sucrose. With the IV iron therapy during pregnancy, the time to maximum hemoglobin levels is shorter with iron sucrose complex compared to ferrous sulfate. You see here in red the time until normalization of anemia is around 6.6 weeks compared to the control, which is nearly, the mean is nearly 10 weeks. So by using intravenous iron, you can nearly shorten or half the time until normalization of anemia, as you see in the red. This is another prospective trial using intravenous iron versus oral iron for moderate iron deficiency in pregnancy. And you see here on the right side, IV favorites IV iron plus IV iron. On the left side would favorite oral iron. But you see that for hemoglobin difference, ferritin, serum iron, and iron saturation, it is all favorable for intravenous iron until post-delivery, and current guidelines should include intravenous iron. Now, these are various preparations that are used in pregnancy. There is now increasing experience with iron carboxymaltose, and as I said, we have a lot of experience with iron sucrose. As you see here, personally, I was never using iron gluconate. The high molecular weight iron dextrans should be avoided because of high incidence of anaphylaxis. There is some experience with the low molecular weight iron dextrans, and also now upcoming with the iron polymaltose. The iron carboxymaltose can be used in high dosages up to 1 gram. It is very effective in correcting iron deficiency. It can be given either as a rapid administration, and it has a very low immunogenic potential, so no free dextran derivatives, no cross-reaction with dextran antibodies, and no test dose is required. Around 15 milligram per kilogram body weight can be given, which for a 50 to 70 kilo woman is around 1,000 milligram. So the uptake of the ferric carboxymaltose is very physiologic. It can be uptaken by a transferrin. It can be delivered to the directly to the macrophage, and can be delivered to ferroportin and the ferritin, and then released in the bloodstream. Again, here you see the maximum single iron dose for carboxymaltose, which is around 1,000 milligram. The maximum dose for gluconate is 62 milligram, for example, and iron sucrose 200 milligram. All substances can be given by infusion. The time for dosing for carboxymaltose is 15 minutes once a week, and iron sucrose infusions are around 30 minutes or a bolus of 10 minutes, and it can be given 3 times a week. This shows you, this study shows you a comparison of high-dose carboxymaltose versus iron sucrose. This is a retrospective study comparing these substances, and you see the local and systemic adverse events. There is in dark gray, the systemic adverse events with carboxymaltose are a bit lower than with iron sucrose, and the total adverse events are also a bit lower. Both substances are very well tolerable in higher dosages. On the right, you see the hemoglobin before for carboxymaltose and iron sucrose, and the rise in hemoglobin was 15.4 versus 11.7 compared to iron sucrose, which is not statistically different. So both substances can be used to normalize anemia and can be very well tolerated. This is a study, a prospective study in 65 patients using 50 milligram carboxymaltose per body weight, which is around 1 gram of total dose. And you see here the increase until 6 weeks post-infusion, and then the drop after delivery. But it's easy to see that with the intravenous iron, you have a nice and steady increase of hemoglobin. This is the same study. And here you see the women split by severity of iron deficiency at the study enrollment. And you see here the groups for mild, moderate, and severe anemia. The pre-infusion values between 8.3 and 10.2 hemoglobin. And then 6 weeks after infusion, all subgroups have normalized for values between 10.8 and 12 gram per deciliter. And so we see that independently from the subgroup, the substance is normalizing anemia in all groups. We have recently, 3 years ago, we have finished a multi-center study on carboxymaltose versus oral iron in iron deficiency in pregnancy. We were comparing 250 patients that were randomized to carboxymaltose 1 to 1.5 gram versus oral iron over 12 weeks. And you see here the groups, 123 women with carboxymaltose versus 124 women with sulfate. The baseline hemoglobin levels below 10 in both groups, and the baseline ferritin was 12.1 and 12.3. So this was clear iron deficiency anemia, and most women were treated around 20 to 33 weeks. You see here in the upper left the increase in hemoglobin over 12 weeks. This is a non-inferiority study, and it shows that one shot of iron carboxymaltose, 1 gram, was as efficient as to give 12 weeks of oral iron. On the lower right, you see the increase in ferritin, and what you see nicely in red is that the ferritin is highly increasing after intravenous iron. And what is interesting that this effect keeps up prior to delivery. So we have 64 women prior to delivery that are still iron supplemented. And this shows that a single shot of carboxymaltose improves iron stores for a long time. Interestingly, we saw also changes in fatigue and levels and vitality score. Here you see in red the changes in vitality score in the upper picture, and below in the social functioning. And what you see here on week 3 and prior to delivery, that after intravenous iron, the women have considerably better scores in vitality and social functioning. So this is another argument to replace with intravenous iron, because it has a higher impact on the social functioning. The treatment-related adverse events were same in both groups. So in carboxymaltose, the total was 60 and the sulfate was 50. So no differences in adverse events in intravenous versus oral iron, and no negative impact on the newborn. This was a study with carboxymaltose in postpartum. What you see here is that at baseline, the anemic groups, and then you see the increase in both groups. One shot of carboxymaltose was as effective as 12 weeks of oral iron. There was a significantly greater ferritin response with carboxymaltose than with sulfate. Here in red, you see easily that 12 weeks after administration, iron is ferritin is higher than in the carboxymaltose group. This was another study from an American group where you see the time after treatment in postpartum anemia, and you see in red that 14 up to 42 days after administration, the number of patients with hemoglobin over 12 is considerably higher in the intravenous iron group. This is another study from 2008 with patients achieving hemoglobin over 12 or having an hemoglobin increase over 3. And again, you see in red the better course for intravenous iron. So in all relevant parameters, intravenous iron was found to be superior to oral iron in the postpartum anemia, and the authors conclude that carboxymaltose is safe and well tolerated. Now today, in postpartum, we have most guidelines are including intravenous iron in their guidelines. So this is true for Switzerland, Germany, the Asia-Pacific region, and also concerning the NATA recommendations. NATA is the network on alternatives to transfusion, and especially for hemoglobin values below 10, most societies are including intravenous iron in the guidelines. The same is true for pregnancy. Also here, especially for hemoglobin below 9, or non-response to to oral iron, like in the UK, intravenous iron is recommended. And again, for Europe, as these countries favor IV iron in anemia and risk patients, this is true for Germany, Switzerland, the NATA, and the British Society of Hematology. For Asia, Pakistan, India, Malaysia, Singapore, Indonesia, China, and Thailand are using intravenous iron. In the USA, there's no clear statement from the ACOG, but there are key opinion leaders in hematology that are promoting intravenous iron. Same for Australia. For Africa, we have no clear data. To finish, just a quick look on cost versus benefit. First of all, the total costs for a possible administration of 1 gram are quite low for carboxymaltose. As you see here, if you take the whole drug costs and administration costs, you have around $270 for carboxymaltose and $370 for iron sucrose. Both are still better than the other preparations. So if you take the total costs, I think there is a cost-benefit ratio. Also remember that early and effective iron therapy might have prevented transfusion in 11% of women in a cohort who is iron deficient. So also here, if you can reduce the number of iron deficient women, you will reduce blood transfusion, and this is cost effective. So to conclude, unfavorable iron status prior to pregnancy and changing iron needs require proactive assessment and management of iron status in pregnant women. In case of mild anemia and sufficient available time, oral iron can improve hemoglobin levels before delivery, but consider different side effects of different iron compounds. Intravenous iron normalizes hemoglobin levels more rapidly and in more patients than oral iron. Established treatment recommendations for anemia in pregnant women should be taken into consideration. So thank you very much for listening. If you have time, and I hope Corona will be better soon so we can travel again, please come to visit Switzerland. You can come to the city or the river or the lake and hang around in this beautiful city. Or you go to the mountains. So thank you for your attention and the invitation to this web seminar. And thank you for recording my talk, and I hope I could support you and give you some good messages. Thank you.